Thank you. Thank you, Kusum. I would like to thank the college for inviting me to participate on this mini congress and to share my thoughts on this, which is acute management of ocular chemical burns. As you know, this is a very challenging thing to treat, both for the patients as well as the treating ophthalmologists, because unlike the endpoint of healing, which is wound healing, the endpoint of this treatment would be the vision, if we can get the vision back to normal. Since the majority of these injuries occur at work, protective eye shields are mandatory when you use them. And like what Dr. Ishantha mentioned, one of the main problems we are having are these chassis of Lyme. And although we have sort of got down the number of injuries, they still happen with these children having access to these chassis and having ocular injuries due to the alkali in it. How does it occur? Usually what occurs is there's a necrosis of the conjunctival and corneal epithelium, which leads to the disruption and occlusion of the limbal vasculature. What this does is it leads to loss of limbal stem cells, ultimately resulting in conjunctivization and vascularization of the corneal surface, with the final result of being persistent corneal epithelial defects with sterile corneal ulcerations. Usually what we say is the immediate is at the moment of contact with the agent, and acute is the initial 7 days of the chemical injury. The early reparative phase is between 7, 8, and 21 days after injury, and the late reparative phase. What we coin the term acute ocular burn is burns with a duration of less than 3 weeks. If you look at the medical management, we had two parts, the medical and surgical management. Medical management, the first and foremost, we have to remove the offending agent. We have to do copious irrigations. We have to promote the epithelialization, minimize the formation of ulceration, control inflammation, and visual rehabilitation. Before any ophthalmic examination, what we have to do is, if there's a chemical injury, we have to check the pH of the eyes. And if the pH is not within the physical range, which was discussed earlier, between 7 and 7.2, we have to go for irrigations. And when do we know we can stop the irrigations? We have to wait at least 5 minutes after stopping irrigations and recheck the pH, because sometimes there can be a secondary rise due to remaining particulate matter. So after irrigation stops, wait for about 5 minutes and recheck the pH of both eyes. So what are the fluid that we can use? We can use, what they have said is, at the initial point of injury, use any clean water that is available. Tap water, bottled water, any water that is available, just clean the eye, irrigate the eye. And after that, in the hospital setup, we can use normal salines, Ringer's lactate, or phosphate buffers. But the main point is irrigating the eye as much as possible to get the pH under control. After that, what we do is we have to check the palpebral fissures for any retained lens matter. So at the slit lamp, you can evert the eyelid, and what I usually do is I usually have a cotton bud. With a cotton bud, you can evert further, and you can do a sweeping movement of the eyelids to see whether there are any retained matter that comes up to the cotton bud. If that is the case, then it is mandatory that you take the patients to the theater and do a proper examination under the microscope to remove any of the remaining foreign bodies that are there. And after that, you can go for a proper examination. You have to use fluorescence to see the staining. And at that moment, you can check the intraocular pressure, because after some time, the cornea can get edematous and it might be difficult to find the intraocular pressure. So you have to have an initial intraocular pressure measurement. Then we have to classify and grade it so that we know the prognosis of that patient. So to do that, we have to use fluorescence staining, like I said, estimate the depth of corneal penetration, loss of stromal clarity, assess the conjunctival penetration, and limbal ischemia. There are various classifications, but the two that we are using are the Roper Hall and the Dua classification. I won't go into details of this, but there are 4 grades in Roper Hall and 6 grades in Dua classification. And for Dua classification, you need the conjunctival assessment. So we have 6 quadrants, the upper fornix, lower fornix, and the 4 central quadrants. So you can add them if there are areas of multiple involvement. Because the dual classification came about because of the drawback of the Roper Hall classification, because the extent of damage was assessed by corneal haze and amount of limbal ischemia. But what we found out was if there's any remaining limbal stem cells that are available, then they can repopulate the cornea and give a better visual outcome. Because all cases in grade 4 who had limbal ischemia, even though they have severe limbal ischemia, if they have any remaining limbal stem cells, they can have a better prognosis. So like I said, Roper Hall had 4 grades and DUA has 6 grades. And we have to have the extent of limbal and conjunctival involvement. And these are some of the pictures of chemical injuries. And if you can see this, on the left-hand side, it's a grade 4 classification Roper Hall, but after ocular reconstruction, the patient had a better outcome. And even grade 5 of DUA classifications, they can have better outcomes if they are managed properly. And this shows a patient with limbal ischemia. So like I said, you have to promote epithelialization, reduce inflammation, and prevent further complications from occurring. Medical management, you have to use artificial tears, which are the mainstay of treatment. If you have preservative-free tears that are available, that is the best one to use because you are using frequent instillations. After some time, you can have corneal toxicities. So preservative-free are better if you can use. And they have to be used either hourly or 2 hourly. And they may prevent persistent epitheliopathy, reduce the risk of recurrent erosions, and accelerate the visual rehabilitation. If available, we can use topical ascorbic acids. But I don't think we have it available here. I use usually vitamin C, 500 milligrams oral 4 times a day, and I usually use it for at least 2 to 3 weeks or until the epithelium has completely healed. If you have topical drops, you can use it every 2 hourly and use it until the epithelium has healed. Tetracyclines are used either topically or orally. These are not used for its antimicrobial properties, but because they have an effect on the matrix metalloproteases, which can degrade the type 1 collagen, and they prevent the degradation of the corneal collagen fibers, preventing further damage. You can use tetracyclines 500 milligrams 4 times a day, or doxycycline 100 milligrams twice a day with meals. To control the inflammation, we have to use topical steroids. I don't usually start on oral steroids, but topical steroids have to be used, and I have come across a lot of chemical injuries where some of the treating consultants have not used steroids, but you have to use in chemical injury steroids at least within the first week to have the inflammation under control. Topical non-steroids usually do not have a part in the initial management because the injury is such severe that the effects of non-steroids are not effective. And also they can have epithelial thinning and ulcerations occurring. Cyclosporins are not used in the initial phase because usually the dry eyes that are occurring after chemical injury are due to the destruction of the goblet cells and conjunctival closure. And these have no effect, cyclones have no effect in the acute management of chemical injuries. So, like I said, in the first week of chemical injuries, you have to use steroids. And after the first week, depending on the epithelium healing, you can taper it off. You can use prednisolone 1% or dexamethasone 0.1%, starting from 2 hourly in the acute phase of management. Citrate drops, if available, can be used. They are also potent chelator, and therefore they decrease the proteolytic activity. You have to use topical antibiotics to prevent secondary infections. And if there's glaucoma is elevated, you have to use drops to get the IOP under control. And you also use topical cyclophagic agents to manage the ciliary spasms and the eye pain. And oral analgesics may be required in some cases to initially control the pain. We also use topical biological fluids. I have used autologous serum, but you can also use umbilical cord serum, amniotic membrane suspension, and autologous platelet-rich plasma. Usually the autologous serum I use in patients about 4 to 5 times a day, and usually for about 2 to 3 weeks to get the help in the healing of the corneal epithelium. Surgical therapy, you have to debridge the necrotic tissue because these are infective foci. Use amniotic membrane transplantations. Use stenoplasty if there is severe limbal ischemia. Stem cell grafting and keratoplasty are done in the later phase of the treatment management, in the chronic phase of the treatment. Amniotic membrane I've started using quite frequently now. The benefits are twofold. One is physical and one is biological. Physically, it has been shown to improve the patient comfort by reduction of the eyelid friction, and through its physical action, it also prevents the symblepharon formation. So these actions help the patient comfort as well as the reepithelialization. They have anti-angiogenic property, anti-inflammatory, anti-proteases, promote the migration and addition of limbal epithelial cells, and antimicrobial characteristics. What we use is we can use either epithelial side up or the endoepithelial side down. Usually epithelial side up is when you have the amniotic membrane, usually the sticky side is touching the host cornea, and the smooth side is touching the host cornea in the epithelial side down. We can also do what is called sequential sectoral conjunctival epithelectomy, which is basically if there's any ingrowth of conjunctiva, we sort of scrape it off. We can do it under topical, and you can use a topical drop, and then we scrape off the epithelium that is growing on. And then I usually use a number 15 blade to do this. And later on, if it keeps progressing, then you will have to think about stem cell grafting. Conjunctival or tenoplasty is also a surgical maneuver that you might have to do. Like I said, if there's severe limbal ischemia, and it starts in the equatorial region, and you have to go up to the conjunctival sacs. The flaps must be at least 1 to 2 millimeter thick, and usually they should be sutured at the limbus as well as 3 millimeter back to the sclera, so that it's securely attached. And there must be one flap in each dial. And it quickly recovers covered with stratified and even conjunctival epithelium. So in summary, like I said, it's impossible to over-irrigate. Do the irrigation as much as possible to get the pH under control. Take out the necrotic conjunctival tissue immediately because they can be needed for infective foci. Please use anti-inflammatory drugs like prednisolone 1% in the initial phases, at least 2 hourly, to get the inflammation under control. And after the epithelium has healed, or after 1 week, you can taper it off gradually. The limbal stem cell management dysfunction can be treated later on, but like I said, you can do if there's growth of the conjunctiva, you can do a sectoral epitheliotectomy. And also prevent further damage by promoting wound healing and hindering the visual debilitating cicatricial complications. Thank you.